We would like to invite Dr. KVS Harikumar for the next session. He'll be dealing with a case of hyperprolactinemia. Over to Dr. Harikumar, please.
Dr. Bindu, can we have one question till the time we start your sir? Are you routinely getting insulin level, fasting or postprandial? You can.
Insulin levels are not mandatory for making a diagnosis. Having said that, about 80 or 90% of obese patients have hyperinsulinemia. And even in lean patients, about 50 studies indicate 50 to 60% have hyperinsulinemia. I usually get it done because one, it is easier, even if they have a normal glucose tolerance, it is easier for us to, tell them, see, your glucose levels are fine, but please work on your lifestyle and this thing, because easier for us to motivate the patients.
So what the cutoff limit you take for the insulin?
See, based on this thing, fasting insulin levels more than 10 we are taking as hyperinsulinemia. In the studies that we have done, the postprandial levels are usually about 35 or 40. So if the postprandial, because many of the patients have normal fasting glucose, but the insulin levels, they fail to come down at 2 hours. Means, if the 1 hour is peaking, the 2 hour is also peaking. So many have postprandial hyperinsulinemia also. So postprandial more than 40, we are taking as, we are telling them that please work on yourself.
So fasting we take 10 or 15 like this?
Yeah. 10. Okay. 10 based on our studies.
Thank you. So let's have another talk. Yes.
Thank you, madam. Good afternoon, everybody. Thanks to the SPEED team for inviting me again here. Before I start, since it's prolactin and of a lady's clinical setting given to me, may I just know how many gynecologists are there in the hall? Can you just raise your hands? So now I am in trouble.
All full of gynecologists.
Okay. Nevertheless, since it's a lady with elevated prolactin was given to me, the setting we will just take a path of a lady. There is no separate outline for this talk. So that is what I thought, that we will just see a lady progresses in her life with this elevated, how we should do. One slide about general introduction about prolactin. It's the commonest hypothalamo-pituitary abnormality we see in the clinical practice. I am sure most of you also would be seeing the elevated prolactin. And commonest cause, one of the commonest cause of menstrual abnormalities and sexual dysfunction. So important to know. Most other important things, there are very many common physiological causes of hyperprolactinemia that we should consider before actually we start therapies. So that is where it is important. And identifying correct etiology is the key factor. We have 3 isoforms in circulation, the small, big and big. I will just touch upon in later. The role of prolactin is beyond lactation. Now lot of research is coming into the effects on bone, hair growth, something about glucose metabolism in pregnancy, lot of issues, but we will leave that aside. Thankfully, management is mostly medical. We don't have to request our surgical colleagues to do anything for them. We only have to request them not to do. That is the most important thing. So we will come back to the patient. 26-year-old lady, prolactin 178 was the report. Patient has some menstrual irregularities. Some of you have advised prolactin and this is a report. Patient says, I am normal. This report is false. Is it? Can we consider that? It is a possibility?
It can be.
It can be, yes. So first we should look at what are the specific typical clinical features which hyperprolactinemia actually manifests. So galactoria, menstrual disturbances, sexual dysfunction, and if you have a tumor related issues, some systemic disorders which can cause all this, and whole host of drugs what you commonly prescribe can lead to prolactin elevation. So that is important to identify. So it can be there that it's a falsely elevated. No clinical features, but prolactin is 178. Is it possible?
Yes.
Because of? No drugs, everything is normal.
Maybe like stress.
Maybe the
Maybe
Stress.
lactating.
Stress.
Stress do not lead to 178, madam.
Maybe lactating.
Pregnancy. Pregnancy.
Okay,
Pregnancy,
pregnancy,
lactating.
lactating. So you have
Lactating.
covered, I mean, most of you are aware about the causes of prolactin. So that is what I have shown you. The physiological being the top, pharmacological being the number 2. So these are the two things commonly in the clinical practice. The pituitary adenoma, prolactinomas come down below. Okay. The last one, just focus here. There is something known as macroprolactinemia. That is, on biochemistry you will get elevated prolactin, but the lady will not have any symptoms of prolactin elevation. Okay. So three things to be ruled out before you actually home on to a diagnosis of hyperprolactinemia. Drugs. Most of the ladies wouldn't warrant that history of taking a antipsychotic pills in a routine history. They would only come with history of galactoria. Unless you probe further, then only this history will come. So it is very, very important. Somebody would have taken a omeprazole or pantoprazole in the mornings and then given a sample. So all of these things are important before you actually label that somebody has got hyperprolactinemia. Systemic disorders, you will easily get them to identify, thyroid being the commonest, CKD and CLD again. And physiological, stress, physical activity, all of them also can lead, but they generally don't go up to that level of 178. But nevertheless, you should consider them as a possibility. Whenever, because it is prolactin treatment is the easiest thing, so I have not spent much time there. Actually, not to treat, where not to treat is where it matters, so that is why I am spending more time here. There is something known as clinical biochemical discordance. Okay, lot of clinical features about hyperprolactinemia, typical clinical features, but you don't have elevated prolactin in the system, or you have a macroadenoma sitting, maybe a prolactinoma, but still your prolactin comes normal. There is something known as high dose hook effect. It basically tells, it's a two-site immunometric assays what we generally look for prolactin. If you look at, this is the prolactin, this one end is the capture antibody, one end is the detection antibody. If there is overwhelming prolactin, it doesn't let these two bind and it will show falsely as normal. So when you have got very typical symptoms and still your prolactin is coming normal, please speak with the concerned lab or concerned nearby endocrinologist to ask about dilution and then evaluation. So that will give you a a prolactin comes 40 as or 20 as initial report, and when you dilute it may come up to 2000. So it is important to know that there is something known as high dose hook effect. The second scenario is what I have said earlier. You have no clinical features, but your prolactin is very high. So this is what about the detection of dysfunctional or the big prolactin in the serum because of the prolactin big form, isoform. You have three monomers which are there, the monomeric, the big prolactin and macroprolactin. So some of it will be detected. If you have to eliminate that, you have to do what is known as a PEG filtration and then look at estimating the prolactin. So again, this is another important scenario which you should understand in clinical practice. Third, commonly, since majority of your gynecologists, prolactin is pulsatile secretion. Say a prick, the stress of venipuncture itself may push the prolactin to say 28 or 31, and they don't come into prolactinomas or prolactinemias. So it's important to identify that it is pulsatile secretion, and if you have any doubts in such scenarios, preferably do a pooled sample with already a catheter in situ, collect every 15 minutes the values, the serum, and take 1 ml each and then pool that, and then you will get a true whether it is elevated or not. So important to know these things whenever you are actually evaluating the patients of prolactinomas and prolactinemias. The range of prolactin, if you can see, the macroprolactinoma have the highest ones and micro goes down, and the non-functional ones are down below, and the other systemic causes, drugs, they are all close to about 70 to 100. So why this is important is because this is one tumor, the size of the tumor corresponds very closely to the level of the prolactin. It's a beautiful tumor marker. So if you have high prolactin, you can understand or guess that there is going to be a huge sized tumor inside. So some of the studies or some of the reviews have mentioned that generally if your prolactin is below 100, these are the possibilities. Most of the prolactinomas you have above 150, 200. So our lady has 178. So possibly we will consider that she has microprolactinoma. All typical clinical features confirmed. She has, and examination shows galactorrhea. So what next? How to approach further? Once you have ruled out every other issue, then what next?
Thyroid.
Pardon, ma'am?
Investigate for thyroid.
Absolutely. So we just rule a basic biochemical workup just to rule out the kidney disease or other things. Most of the times do a pregnancy test. Almost always this is one of the clue that the lady conceived. Increased T4, increased prolactin mostly are the clues to actually getting to know the diagnosis of pregnancy confirmation. We get a lot of referrals about increased T4 and increased prolactin, and you just do a UPT, it will comes positive. Hormonal, obviously you should look at thyroid and PCOS workup. And imaging, please don't do any CT scans. CT scan has no role in evaluation of pituitary. Mostly, there are some roles, but not majority. You should do a MRI cella just to find out is it a micro or macroadenoma. The management is very simple for everybody. If it is microadenoma, the dopamine agonist is the therapy. The dopamine agonist, preferably most of the people now use cabergoline. You can start with either 0.25 or 0.5 mg once or twice per week. There are very many regimes, high dose, low dose, speed and everything. But generally bromocriptine is not widely prescribed, not widely available, and for the side effects also it is not much being used. And you titrate based on the serum prolactin level and you let the patient on the maintenance dose. If there is intolerance to a bromocriptine, then you can change the dopamine agonist, generally nausea, vomiting being the side effects of it. Macroadenoma, you have to evaluate for other pituitary functions, but the treatment remains again cabergoline. So there is no question of going for surgery here. Only thing is, if there is persistent growth of the tumor or some other pressure symptoms, then you consider surgery, but otherwise mostly it is just amenable to medical management. So patient is improving, married, some advice about how to proceed further, about what to do. She wants to conceive, all those things. So management during pregnancy determines at what stage you have had the disease prior hand. Microprolactinoma, we generally advise to stop the therapy, keep observing. The only caveat being, don't at all observe with prolactin level. Prolactin will obviously be elevated in pregnancy. The only thing is just keep a tab on the clinical features, any severe headaches, visual changes. Then if there are any significant symptoms, then you ask for an MRI. Prolactin has no role in this. Macroprolactinoma, which is amenable to therapy or which has responded earlier, if it is low risk, not abutting the optic chiasm and all, you can consider stopping the therapy and follow up, because the risk of tumor enlargement is more with macro than with micro. So you can take a call. High risk ones, possibly you can consider continuing with the therapy. Few questions which routinely people ask, patients, doctors, everybody. When to stop? Possibly there is actually no clear guidelines. Endocrine Society guidelines almost a decade back said that patient 2 years on the lowest possible therapy without a demonstrable MRI lesion, you can consider stopping therapy. But the follow-up studies have shown that the recurrence rate is almost to the tune of 40 to 50%. So even you may consider stopping, but be prepared that the recurrence rate is a bit more. And what if patients don't respond? That is one very minuscule subset in the clinical practice. The don't respond, the definition is also very clear. You should use maximum dose of bromocriptine 7.5 milligrams per day and cabergoline of about 2 mg per week, and no reduction of tumor size, not more than 50%. So if somebody was using bromocriptine, maybe you can consider switching to cabergoline, because bromocriptine efficacy is about 60 to 70 and cabergoline is about 80 to 90. Even somebody is unresponsive to cabergoline, you have no other option but to recommend surgery. Radiotherapy is not much recommended here, so we will leave it aside. What if I conceived accidentally? You have started therapy and somebody comes pregnancy test positive, just counsel, nothing is going to happen. We have enough data with both the drugs that safety wise there is no problem. Only thing is, as I said before, if it is micro, you just stop the drug and then keep observing and do not abort. We had the discussion about A1C things. Never ever any medical parameter is a indicator for recommending MTPs. So we just don't recommend irrespective of A1Cs. Type 1s, plenty of them conceive with 9, 10, 11s peacefully without any issue. So there is no question of recommending a MTPs because of anything of such things happening. What about giant prolactinomas? If you have a huge ones, again the management is medical only. But only thing is you need to be a bit more aggressive in follow-up. Maybe a monthly prolactin, maybe a monthly visual field, a monthly MRI, because whatever the reduction starts happening within few days. So it will actually give you some clue about how to proceed further. Elevated prolactin and supporting clinical features, no need to repeat the clinical test. Why I have said this is, most of the times in endocrine, when we diagnose any disorder, you need to confirm it or you need to recheck it, all those things are there. But if you have typical clinical features and you have supporting elevated prolactin, you don't need to repeat. A sella mass with diabetes insipidus, possibly elevated prolactin, look at stark effect more, because prolactinomas is an anterior pituitary mass, it doesn't cause the posterior pituitary dysfunction. So that may be possibly because of a stark effect. A hypothyroidism, if somebody has got elevated prolactin, you have diagnosed hypothyroid, you treated for hypothyroidism, the TSH has come to normal, but your prolactin is still elevated. There are few case reports which said that there can be coexisting prolactinomas also. So you should be vigilant about such of these things, that why your prolactin is not coming down. The DD between non-functional pituitary adenoma and macroprolactinoma is very, very important. As I have said, if somebody has got a macroadenoma, prolactin is normal. The first thing you should do is do prolactin in dilution and rule out that it is because of the hook effect. That is the key factor which will tell whether you are actually dealing with a non-functional or a macroprolactinoma, because the treatments are completely different between these two. Something is very amenable to a tablets and something is just not. So that is important to identify. And as I said, size of the tumor correlates with the prolactin level. Last 3 interesting cases I will show you. Microprolactinoma treated, prolactin not reducing. Diagnosis? You have started therapy, patient improved initially, but repeat prolactin is coming again, say 180, 190, 200.
Maybe pregnancy.
100% correct.
Maybe
Most of the times during infertility workup, this picked up, and you start cabergoline, and again they come with an increased prolactin report, which actually is you should be vigilant about pregnancy. Commonest things what happen in clinical practice. One of the another patient which we published a few years back, a prolactinoma, microprolactinoma, patient had visual defects, which we initially thought, okay, let us treat the prolactinoma and see. We kept on treating and kept on repeating the MRIs, which always showed a microadenoma. The optic chiasm is completely separate, but the visual field was almost going on both sides. We were perplexed as to why this was happening when your MRI is showing that nothing to do with optic chiasm, and we looked for all other etiologies, finally homed on to one which is known as idiopathic intracranial hypertension. We did a CSF, it was very high pressure. We put her on acetazolamide and the lady had a marked improvement in her visual fields. The prolactin was always normal all throughout. So you should have some things in consideration when your clinical profile is not fitting with the patient. This was another lady which had multiple microadenomas, which because of pregnancy we had to stop the therapy, and thereafter when we had to restart because of a macroadenoma. And this was only to say of interest because usually the monoclonal origin microprolactinoma enlarges to become a macroprolactinoma, but you may have a polyclonal origin also of the tumor. So to conclude, hyperprolactinemia is a very common in the clinical practice. Identifying the underlying etiology is the most important thing rather than anything else. Macroprolactinoma and macroprolactinemia are not the same, they are completely different. except for few vowels here and there. Always rule out pregnancy before venturing out management. That's one of the commonest things you get when elevated prolactin. Cabergoline is the mainstay of therapy, and this is if at all there is a tumor, it's most sensitive to medical management, and you should be vigilant about some other findings in the management which may come as a surprise to you. I've finished here. Any questions or comments, I shall be happy to take.
Thank you, Dr. Harikumar. I think you have picked up all the points. You have considered all the discussion which is required. And as a gynecologist, we mostly see patients of secondary amenorrhea and infertility. And when we test them, the hyperprolactinemia is there.
Correct.
Any question from the house?
PCOS is considered as an association of hyperprolactinemia in some of the studies, but later on it has not been shown to be that significant association. Say a decade back it was considered as one of the cause, but now there are no pathophysiological links between the two, and some of the later studies have not corroborated that finding. It is more of elevation of say 50, 60, all those things. You don't get that much elevation. So you are actually
Please take mic. Can you take mic?
A patient who had clinical features of PCOS and was going to a gynecologist for infertility only, and typical history of PCOS, and the prolactin was around 70, 78, 80 at repeat measures, no medications involved. And then even got an MRI done, and that MRI showing some small thing, 3 mm lesion, so again got paranoid. And the TSH, because this patient is obese, so we know obesity can lead to some amount of TSH elevation. So now the TSH is also 7. So now there's multiple things happening. Now she wants fertility, she's having menses, she's not positive for UPT, definitely that was checked. So now in this it becomes very confusing to explain to the patient what is happening. And whether to treat this prolactin, because what happens is the gynecologist says treat it with cabergoline. We say no, we say this MRI doesn't mean anything. Meaning endo and gyne mein thoda sa wo ho jata hai. So what exactly should be done in such a case?
I agree. The guidelines say that it is association only between PCOS and hyperprolactinemia, number one. Any amount of elevated prolactin is going to reduce your functioning of the gonadal axis. So definitely in a clinical setting, I would err on to giving a treatment. Cabergoline. Okay.
And thyroid hormone for TSH7 because she's going to conceive.
See, if you have a features, I mean, say you are talking about subclinical hypo in that spectrum. Okay, yes. Subclinical hypothyroidism, one of the indications of therapy is patient's features.
Obesity.
So patient has symptoms, patient has infertility. So what prevents you from making? See, the evidence to get in such scenarios is very difficult, number one. Number two, if you look at the risk-benefit ratio, the risk is overtly minimal than when compared with the possible benefit. So in that prospect, you're going to treat. But otherwise, you don't have evidence that it is going to be beneficial.
Or should we just treat the hypothyroidism first, and repeat the TSH, the prolactin once?
Ideally, yes, because any drug-induced, any known dysfunction, you have to normalize that and then repeat prolactin and then assess.
So subclinical also you would expect it to lead to prolactin elevation, even subclinical hypothyroidism.
See, even the overt hypothyroidism, the series have shown almost the prolactin elevation up to 70 to 80, what I have shown. That is, there are mixture of subclinical and overt. So, but if you have a known factor which is going to elevate prolactin, you eliminate that and then look for prolactin rather than jump and treat everything simultaneously.
Yes,
First you have to
follow
treat
the
the
same
thyroid.
protocol. We
Yeah.
treat high TSH.
First we treat
Maybe
thyroid.
25 micrograms will suffice, and prolactin will also come down.
Prolactin
Absolutely.
automatically
Right.
come down. Yes.
Absolutely.
So as you rightly said, it comes under differential diagnosis as well.
Correct.
It's a diagnosis of exclusion. PCOS is a diagnosis of exclusion. So if you find hypothyroidism, or if you find hyperprolactinemia, first treat hypothyroidism. And side by side explain her lifestyle modification and diet and all. And then 4 to 6 weeks later you check her prolactin level. Might as well, she
Yeah.
might come as normal.
Automatically it will
And,
come.
yeah. If it is not normal, there is no harm in giving.
Yeah, thank you very much, Dr. Harikumar, for
Thank you, ma'am.
brilliant talk. And in case of prolactinoma, macroprolactinoma, when patient conceive, do you instruct patient to change from cabergoline to bromocriptine? Because we have not much trial on the cabergoline.
That was there earlier. There are enough number of studies now with the exposure to cabergoline also, which said that the birth defects are not much even with cabergoline. The recommendations, as I said, the Endocrine Society guidelines published decade back showed or suggested that you should give bromocriptine if somebody is planning for a child in a microprolactinomas. But of late, the practice is not that. Even some of the recent evidence also says that because bromocriptine is actually very difficult to locate.
Tolerate
Tolerate a second, you didn't even get it most of the time.
Very poor.
So you would easily get the same benefit with the cabergoline, and till date the published evidence with cabergoline did not show any extra increase in the birth defects.
So you tell the patient to continue cabergoline.
You continue cabergoline, stop the moment your pregnancy test is positive.
No, after pregnancy positive only I am asking you.
After positive, we are not treating anybody, whatever be the drug.
Yeah, then
After positive, you are not treating.
After positive, we change cabergoline to bromocriptine.
No. After positive, the recommendation is to stop anything.
Macroprolactinoma.
Macroprolactinoma, if it is a high risk one, you continue the same drug.
Same drug, cabergoline?
Yes.
Don't change.
Don't change.
Okay.
Macro only with a high risk one.
Yeah. Only.
Okay, ma'am. Thank you.
Thank you very much. Thank you, organizer, for the wonderful interactive session and being us there. Thank you.